Do y'all see the recording? Okay. So good afternoon, everyone, and welcome to the first public session of Laid Black, a conversational series on race in medicine and medical education. My name is Farrah-Amoy Fullerton. I'm a fourth-year medical student at UABSOM, and I'm an aspiring pediatrician. My professional interests lie in health equity, and I will be your host and moderator for today's session on racial inequities of coronavirus. So before introducing my panelists for the session, I'd like to take a moment to thank everyone. Let me let everyone in while I'm talking. I just want to take a moment to thank everyone for coming in to listen and to learn. We have a variety of people from a lot of different backgrounds and clinical experiences, so it's going to be important to respect all the different varying perspectives we're probably going to hear tonight or today. So the two main themes I want to emphasize for every session of Laid Black are growth and community. And I intend for all voices to be heard equally in an effort to heal and grow as a society. So if you'd like to keep up with conversation, Laid Black is on Twitter and Instagram at the handle Laid Black Live. And now that I've introduced myself and told you a little bit about what Laid Black is about, I'm gonna have my panelists introduce themselves, starting with MD-Ph.D. student, Neda Ilieva. We're actually both executive officers of the Medical Humanitarian Interest Group. So I just want her to talk a little bit about that while she introduces herself.
Hey, sorry about that. Let me get my cat off of here. Hold on. So basically, I am a second year MD-Ph.D. student. Obviously, that's not the main relevance of this, but as far as understanding the science and having a background on racial and health disparities, it is really important to me going forward because the statistics are there. And the research is there, and the science and support for that is also there. So as far as medical humanitarianism interest group goes, the role for that is really to kind of bring on similar kind of style panelists, but discuss racial disparities, discuss social inequity, discuss discrimination, and also basically anything that is a foundational factor in unequal care or even, social determinants of health. So the one thing that I do really look forward to with that group is that we have 18 faculty ranging from all different positions of life. We have rural faculty, we have Black faculty who are both MD-PhDs and MDs. We have, Latino, we have pretty much a broad range of people who are amazing speakers on their experiences within the healthcare system. So my role for today is really just going to be to highlight some of the critical aspects of the research that is out there right now, and also to kind of speak on that from my perspective as an MS2 coming into this. So that's it. And Edgar, if you want to go.
Yeah, I can go. Hi, everyone. My name is Edgar Soto. I am taking a year out to do a TL1 MSPH program right now. And I am the former president of the UAB Latino Medical Student Association. And I'm a first-gen immigrant and medical student. So that's the perspective that I'm bringing to the table. Dr. Hill, you want to go?
Hi, everybody. I'm Samantha Hill. I'm an instructor within the Department of Pediatrics Division of Adolescent Medicine, which basically means I see 11 to 30-year-olds for the most part with different things all day. I specialize within that as the Director of Sexual and Reproductive Health, specifically working on improving access to long-acting contraceptives, as well as HIV care and PrEP care. I'm also a clinician researcher, and my research focuses on those areas. And right now, it's really focusing on improving access and uptake of PrEP to particularly African American, Latino, and rural communities within Alabama. And that does encompass LGBT in general, but specifically focusing on those areas. I'm also the president of the UAB Minority Health and Health Research Center Young Professionals Board. I'm the faculty advisor for the UAB Underrepresented Medicine House Staff Council and one of the co-founders, co-chairs of that. I also am a co-founder of a mentoring program at Carver High School, which is a Birmingham City school, predominantly Black and Latino, specifically working with their health academies to increase the pipeline of Black and Brown individuals into careers in healthcare. And so we focus on not just MD, but PT, OT, speech, dentistry, social work, psychology, public health, and so on and so forth. And then I see some of the people on here that I recognize that are doing awesome things in general. But my career has kind of been a hodgepodge of what they tell you not to do, which is that I have interest in clinical research, advocacy, and teaching. So try not to do that. But they all center around improving disparities in health for individuals, particularly living in the South. I trained, just some background, I went to Duke for undergrad. I did 2 years at the NIH doing research, and it was basic science research, and realized I did not want to do that. And so left research entirely, and then went to Morehouse School of Medicine, which is a predominantly African-American institution. So it definitely went from a predominantly white institution to African-American institution to get my MD. Then went to Thomas Jefferson Hospital in Philadelphia and AI DuPont Hospital for Children in Delaware to do my pediatric residency before coming to UAB here to do my adolescent medicine fellowship and stayed on as a fellow. I also completed my master's in public health here at UAB with a focus on health policy and leadership. So that's kind of me.
Thank you so much, Dr. Hill. You are aptly qualified to be on this panel, and I thank you from the bottom of my heart for taking the time out of your day. So thank you again, everyone, for accepting my invitation for the talk. Just want to set up a few guidelines for today. So number one, panelists are going to be the ones leading discussions. So they're going to be speaking briefly after each slide, and then after they speak, the audience will have a chance for commentary. And number two, if an audience member would like to speak, you have to state your name, where you're from in the chat with a request to comment, just so we have like an order and a queue to where nothing is too chaotic. And for number three, feel free to use the emoticons during the session, but no, they won't be a way to, you know, reserve your spot to say something, because I can't keep track of that while I'm trying to talk. And then for the last one in the chat, I'm gonna provide some links, let me pull up the chat right now, to a Laid Black mailing list and all social media handles so that everyone has a chance to stay up to date. And so the mailing list is just gonna give you updates about when chats are gonna be, what the topics are gonna be, if options, if you'd like to vote. Instagram and Twitter links are also there. I also have a post-session survey for you to do once you're done, just to tell me how I'm doing. So now that we got all of the logistics out of the way, we can go ahead and start with our presentation. So 1 second and I'll share my screen. Okay, so like I said before, today we're talking about the racial inequities of coronavirus and how COVID-19 has disproportionately affected Black and Brown communities. And so before we delve into this topic, I want to just quickly take the time to watch a video from David R. Williams and how racism makes us sick. I won't give an intro and we'll only watch the first 10 minutes, but I think it's very relevant to our discussion today.
Pictures of Black. An article in the Yale Alumni Magazine told the story of Clyde Murphy, a Black man who was a member of the class of 1970. Clyde was a success story. After Yale and a law degree from Columbia, Clyde spent the next 30 years as one of America's top civil rights lawyers. He was also a great husband and father. But despite his success, personally and professionally, Clyde's story had a sad ending. In 2010, at the age of 62, Clyde died from a blood clot in his lung. Clyde's experience was not unique. Many of his Black classmates from Yale also died young. The magazine article indicated that 41 years after graduation from Yale, the Black members of the class of 1970 had a death rate that was 3 times higher than that of the average class member. It's stunning. America has recently awakened to a steady drumbeat of unarmed Black men being shot by the police. What is even a bigger story is that every 7 minutes, a Black person dies prematurely in the United States. That is, over 200 Black people die every single day who would not die if the health of Blacks and whites were equal. For the last 25 years, I have been on a mission to understand, why does race matter so profoundly for health? When I started my career, many believed that it was simply about racial differences in income and education. I discovered that while economic status matters for health, there is more to the story. So for example, if we look at life expectancy at age 25, at age 25, there's a 5-year gap between Blacks and whites. And the gap by education for both whites and Blacks is even larger than the racial gap. At the same time, at every level of education, whites live longer than Blacks. So whites who are high school dropouts live 3.4 years longer than their Black counterparts. And the gap is even larger among college graduates. Most surprising of all, whites who have graduated from high school live longer than Blacks with a college degree or more education. So why does race matter so profoundly for health? What else is it beyond education and income that might matter? In the early 1990s, I was asked to review a new book on the health of Black America. I was struck that almost every single one of its 25 chapters said that racism was a factor that was hurting the health of Blacks. All of these researchers were stating that racism was a factor adversely impacting Blacks, but they provided no evidence. For me, that was not good enough. A few months later, I was speaking at a conference in Washington, D.C., and I said that one of the priorities for research was to document the ways in which racism affected health. A white gentleman stood in the audience and said that while he agreed with me that racism was important, we could never measure racism. We measure self-esteem, I said. There's no reason why we can't measure racism if we put our minds to it. And so I put my mind to it and developed 3 scales. The first one captured major experiences of discrimination, like being unfairly fired or being unfairly stopped by the police. But discrimination also occurs in more minor and subtle experiences. And so my second scale, called the Everyday Discrimination Scale, captures 9 items that captures experiences like you're treated with less courtesy than others, you receive poorer service than others in restaurants or stores, or people act as if they're afraid of you. This scale captures ways in which the dignity and the respect of people whose society does not value is chipped away on a daily basis. Research has found that higher levels of discrimination are associated with the elevated risk of a broad range of diseases, from blood pressure to abdominal obesity, to breast cancer, to heart disease, and even premature mortality. Strikingly, some of the effects are observed at a very young age. For example, a study of Black teens found that those who reported higher levels of discrimination as teenagers had higher levels of stress hormones, of blood pressure, and of weight at age 20. Distress of discrimination is only one aspect. Discrimination and racism also matters in other profound ways for health. For example, there's discrimination in medical care. In 1999, the National Academy of Medicine asked me to serve on a committee that concluded based on the scientific evidence that Blacks and other minorities receive poorer quality care than whites. This was true for all kinds of medical treatment, from the most simple to the most technologically sophisticated. One explanation for this pattern was a phenomenon that's called implicit bias or unconscious discrimination. Research for decades by social psychologists indicate that if you hold a negative stereotype about a group in your subconscious mind, and you meet someone from that group, you will discriminate against that person. You will treat them differently. It's an unconscious process. It's an automatic process. It is a subtle process, but it's normal, and it occurs even among the most well-intentioned individuals. But the deeper that I delved into the health impact of racism, the more insidious the effects became. There is institutional discrimination, which refers to discrimination that exists in the processes of social institutions. Residential segregation by race, which has led to Blacks and whites living in very different neighborhood contexts, is a classic example of institutional racism. One of America's best kept secrets is how residential segregation is the secret source that creates racial inequality in the United States. In America, where you live determines your access to opportunities in education, in employment, in housing, and even in access to medical care.
So I'm gonna stop the video right here because I really want y'all to hang on to the last couple words he just said. Where you live determines all of these aspects of your life. So I'm gonna open up to my panelists first, just to talk about important aspects they thought were really good in this video.
So I can start. I think I listened to him, and I actually have the virtue of listening to the entire thing, but I think it's really important to think about the differences in how race affects health, as well as how racism affects health, because I think those are two different things. We all know race is a social construct, so in reality, there are really no differences between racial groups. But because we have made this social construct and it has led to racism, we actually see broader implications. I think when we talk, when he's about to get into this point of, one person's behavior to another person is detrimental, but when it's behaviors amongst a group, which would be the difference between race versus racism, especially institutionalized racism, then you start to see these broader impacts of health overall amongst the people that are being discriminated against. In this case, he's talking about Black, brown individuals in general. And so I love where he ended, where he was talking about how where you live determines things. I happened to be fortunate enough to be on a call with the YWCA of Central Alabama a week or two ago, and my whole message was, where you live determines your access to food. It determines your access to jobs. It determines whether or not you have access to a job that's going to allow you to take time off if you feel sick, or if it's going to continue to force you to come to work and worsen potentially what you're experiencing. It determines whether you have access to certain types of education, certain loans to buy a house, certain loans to be able to start your business. And all those things play a part. And a lot of those things also link back to your actual race, but they have come about because of the racism in our economic, our medical, our educational, our financial institutions.
I think further expanding on that, From the research perspective, it also is a big reason why we have such limited enrollment in clinical trials from Black and, colored patients in general. Even when I was in clinical research in my post-bac, my 1 year and 7 months that I was there, basically, it was extremely disheartening to see that the proportion of Black patients that I had enrolled in my studies, although they were paid, although we had, offered medical excuse notes, et cetera, the unfeasibility of our patients to actually make it because of a job conflict and because of other obligations like family care, other things like childcare, et cetera, it was a large detriment for patients getting care. And then another thing that people don't consider is that, especially in low SES communities where it is redlined and you basically are stuck within that construct, you're stuck within that system. There is also the lack of childcare that becomes a burden, because then these patients have to figure out how they're going to get to their appointments if they have a child to bring with them, and the doctor's office is not receptive. They don't have a child care area where the parent can drop off their child so they can be sure that they're taken care of. And unfortunately, child care is expensive, and that's another expense that they then have to think about as well. So it is something that we often have to kind of plan strategically in terms of enrollment. And I think that research on our end can do a better job of making sure that we can include these patients by offering things like this for them, in order to ensure that we are getting the most accurate data to include all of our patients.
So I forgot to mention my other hat is I was a teacher before I became a medical student. And over the last year, through the Schweitzer Fellowship, a friend and I were able to kind of tackle some of the education kind of inequalities seen here in Birmingham. And I think for me, education is that microcosm that kind of shows it, especially in a city like Birmingham, where there is literally a huge difference in health outcomes based on just looking at going to college from a student who grew up going to Birmingham city schools compared to over the mountain schools. And it's just this weird, frankly, infuriating, interconnected mesh of structures. So whenever someone, it just goes back to that root of someone is that community just has diabetes, or that community has congestive heart disease, right? These are just the comorbidities. No, it's not. It's the social determinants of health that are preventing them from even processing that there is something happening. Yeah, and that's, yeah.
Further speaking, oh wait, was somebody else speaking? Sorry, go ahead.
Go ahead, I was just saying, okay.
Yeah, I was just gonna mention Justin's point that he mentioned in the chat comments for those who are joining just on telephone. Justin mentioned that the distrust of the medical system is a large reason why we have this. So he mentioned the Tuskegee syphilis case, and then he also mentioned Henrietta Lacks, and then obviously there's a lot of things that are happening right now. And that is a pervasive problem because of the abuses of the medical system of Black patients, especially. And not to mention, there's also the OBGYN in New York, whose statue is still there, who basically practiced medical techniques on Black women without anesthesia, and then of course took those techniques to European patients who were Caucasian and actually did anesthesia on them. So it is horrifying to think about, and it is something that we definitely can work on addressing, but we have to be empathetic to the distrust and effectively earn the trust of our patients in order to move that forward. And then another mention was the leader of NOI, Farrah-Amoy, who basically gave an address doubting COVID vaccines. And this is a big issue right now, especially, is that if a COVID vaccine were to come out, there are a lot of issues with that, right? And in mentioning HIV/AIDS and other, trials for vaccines, we've had a lot of global issues with the administration of these vaccines to patients in Africa. And these administrations basically, without any sort of, trial or, safety preventative measures, because the biggest problem is that in the United States with the FDA, we have a kind of systematic regulation of that, but abroad, there's a little bit less of a stringency, there's a little bit less of a preventative safety measure. So patients did get abused overseas with that. So it is frightening to think about. And I think that, again, that goes back to the stress point there too.
A couple of things that I had to add. I think, especially with research, a large problem that we have is that we don't involve the community at the beginning of our experiments. Experimental design, even our interest. I know as a researcher, especially as someone beginning her career in research, that's one of the first things I do. I figure out who I really want to work with, and then I actually go find my community partners who give me valuable insight, because I do have a bias, right? I've gone through all this medical training and I see patients on a regular basis. And sometimes we forget that makes us different than the average population in the regards of doing research. And so making sure that we do that. But I want to also mention just the intersectionality all of us have as future clinicians, and that just because you have gone through medical school does not mean that when a vaccine comes out that you're going to hop in line to get it either. I have these conversations with my family. I was born and raised in the South, born and raised understanding many of the atrocities at a very young age, because my family believed in making sure I could read. And they gave me a lot of not so gentle literature to read as a child that was in like 3rd grade. And, so I can say as a person, this might not apply to everybody, but even I have doubts. I'm sure they will mandate something that says, once a vaccine comes out, if you're a UAB physician, you get it. But I'm speaking as Samantha and not as Dr. Hill. I'm never confident in being the first person to test out a vaccine. And I'm a physician, and I have the ability to read the literature and understand the pros and cons and what the literature is actually saying. And I'm still not even comfortable. And so we have to keep those kinds of things in mind. I think we have to keep in mind the way we talk about research. I know when they were first talking about COVID-19 vaccines, the very first thing was, well, let's go test them out in Africa. And as a person of color, I was like, I'm looking at Africa's rates. They're not even close to anywhere over in Europe and the United States. And it's exactly what Neda said as far as the FDA being stringent, but you are imposing a clinical trial in a population that's not really being affected by the illness, and therefore has the potential to really be adversely affected by the trial of the vaccine. And unfortunately, in the United States, that's how we tend to group think. Individually, we might not think that, but as a group, we tend to think that. And those kind of things do nothing as far as convincing communities of color to seek help, or to try out different treatments that are not necessarily natural or from naturopathic doctors. And so we really have to be aware of how we go about our practice, our research, our advocacy, our teaching, and making sure that we're actually doing it from a place of love, using cultural humility, using trauma-informed care, using our implicit bias training. All of these things we have to live and breathe and do every single day, regardless of your color.
Thank you so much, Dr. Hill, because I was actually thinking the same thing. The way they were talking about it and like how they were trying to distribute it once it was developed, I was like, this does not sound ethical in the least. And it's just like a slap in the face, because we have all these well-documented atrocities. Why are we doing the same thing over and over again? So yes, let's start with our slides. Because this is our first public session and we have a mixed variety of participants, we're going to just start with, what exactly is COVID-19? Because we've been seeing it in the news. And so I think the best way to present this is to kind of compare it to the one thing we all have experiences with, which is the flu. I've had the flu a couple times. I've had to get the flu vaccine. So I think it would be best to compare the two. So if we start going down the chart, and this is for people that are listening in and they can't see the slides, it's basically a chart comparing COVID-19 and the flu. The incubation period for COVID-19 is way longer, 2 to 14 days. For the flu, it's just 1 to 4. Their symptoms are pretty similar, but the flu comes with body aches, pains, headaches, chills, and COVID-19 comes with your standard kind of fever, cough, fatigue, shortness of breath. So it's honestly difficult to even say, hey, do I even have COVID-19 or is this just a flu? So there's a lot of confusion there as far as, people being unsure where to go to seek help, if they even do need to seek help, costs of what seeking help would mean. So there are some less common symptoms that are associated with both of them. I know the most prevalent ones for COVID-19 are GI symptoms, so nausea, vomiting, diarrhea, and those can happen in the flu too. So it's kind of difficult for the everyday person to be like, what's going on with my body? And very scary, understandably, right? So the symptom onset for COVID-19, we talked about the really long incubation period. So the onset is pretty gradual, insidious, and a lot faster for the flu. But the main thing I want to make clear when we're distinguishing the two is that COVID-19 is a lot more severe. If we're going to compare their mortality rates, the flu has a mortality rate of between 0.1 to 0.3, so less than 0.5% of people are dying from the flu, right? But when we go to COVID-19, that number is increased from 0.3 to 3, the whole 3 to 4%. And that doesn't seem like a lot, but when we're talking about a country as big as the United States, that is a lot of people. And as I'm sure y'all have seen in the news, on Twitter, on social media, cases are getting up there. There are hot spots all over the country. It's not even because the mandates aren't even. So it's honestly the response has not been consistent. I will say that. And so there are other things on the comparison chart for COVID-19 and the flu. I don't think they're as important to say, but if there are any questions, you guys can go ahead and ask the audience or the panelists. And I'll just wait a few seconds to let those questions come in.
I just want to add, symptoms-wise, while we're waiting on questions, loss of taste, loss of smell, and remembering that you're actually most infectious. If you are going to have symptoms, you're actually most infectious 24 hours before the symptoms come on. And that's, I wouldn't be here if I don't want to plug. That's why you should wear your mask or stay at home, preferably, because you're more likely to spread it before you even know you have it. So.
Yes, please, please, please wear your mask. Doesn't seem that there are any questions, so we're just going to move on to the next slide. And we're going to just talk a little bit more about the disparities that we are seeing with COVID-19. So as we talked about before, Black and Brown communities, African Americans, Latino residents, they're 3 times as likely to become infected than white people. And so, and if we're just taking just that and add on to being twice as more likely to die once contracting the disease, like something's not adding up. So one thing that I wanted to also emphasize when we talk about Black and Brown communities, that we do not forget the Indigenous people. So in Navajo Nation, which is pretty much comprised of Arizona, New Mexico, and undocumented as well. So their infection rates are astronomical, and it's honestly a travesty that they are dying at the rates they're dying, and the response has been so slow, because unlike other groups like Black people and white people, the United States government is required to give them the care, the health care, and the funding that they need to combat this, and they have been falling short. And so as of the 14th of June, 6,611 cases confirmed, and more than 300 have died from the virus as well, which is a total higher than 15 states in just the Navajo Nation. So if anyone wants to speak on that, you can go ahead.
So a large factor for that is honestly the IHS, which is the Indigenous Health System. So I don't know how familiar people with, are with that, but each nation kind of has their own system, and typically tribal nations do have the IHS, which functions as their medical body. However, the IHS has been under fire, literally multiple times, because they have a tendency of hiring physicians who basically have had multiple malpractice suits, physicians who have been, basically had their licenses revoked in multiple states. It is bad because we're not willing to work as educated physicians within these nations. And it is disappointing because their quality of care has fallen so short. In a recent report, they actually highlighted the fact that there is such a shortage of medical staff within the IHS right now that effectively people who have zero role in direct medical care, like therapists and counselors and people who are in psych health, as opposed to other things, are basically starting to get involved in COVID care. And they are so overwhelmed, and they're just trying their best. And unfortunately, right now, they have fallen short in their capacity and ability to actually care for these patients. And the $8 million that was promised for IHS care basically was not delivered. So these patients also did not receive the federal aid that they were promised. And unfortunately, that led to even further damage in health within their community. And I think that obviously sending more aid right now will help. That is definitely a true thing. However, we need to start addressing why there is no good foundation of care within those communities to begin with, and why these malpractices really continue to happen within the IHS, and why they're permitted to happen at a federal level. If these atrocities were happening closer to our home, I think it would be a lot more pertinent for us, and we would be shocked and kind of trying to beat down the doors and try to get an overhaul of the system. But it has been a plight that's been ignored for far too long. And honestly, that's really important for us. MHIG and I were planning on actually bringing in somebody who is a physician within the IHS to kind of try and speak to us about that, and basically to give us an appeal on why it is important to get good physicians into the IHS, and how we can basically help to bolster that system to support our Indigenous people. So if anybody else has any thoughts on that, please go ahead.
Yeah, so, I agree with what you said. And I think the Navajo Nation is a great example. And there are places, I wanted to specifically say, there are places right here in Alabama that if you, for whatever reason, are having difficulties relating to the Navajo Nation, because it is in the southwest portion of the country, there are places here. For whatever reason, and I mean, I'm sure people could brainstorm on their own time because it's not the purpose of this panel, but as we finish our training in healthcare as physicians, we do not always go and seek to be where we are most needed. I'll speak from my own experience, moving from Philly to Alabama, especially as a Black woman, especially as a Black woman from the South who knows what the South does, represents. I got a lot of pushback about why I would take my expertise and skills to a state like Alabama. And Alabama's got all these great things, but I think for some of you, especially if you've never lived outside of the state, you need to understand how other people see the state. And this goes for many states throughout the country. And for whatever reason, it seemed odd that I would choose to go to a state where I would be paid less, where I would probably be treated worse because of the color of my skin and my gender, because we're in Alabama, as opposed to being in Philly where I would be making bank right now. I took a pay cut just to be a fellow. I went back to like my first year of residency salary to be a first year fellow here in Alabama. So, people ask those things. And I think we in our medical training need to ask ourselves, why don't we go to places like the Navajo Nation? Why don't we go to Wilcox County? Many of you guys may or may not be familiar with Wilcox County right here in Alabama. That's a county where, I hate to say it, they actually still racially segregate their schools. That's actually the rule of the land in Wilcox County, Alabama. Specifically in Camden, Alabama. If you are white, you go to one school. If you are Black, you go to the other school. And virtually no other races really exist within that area. When I first moved here as a first-year fellow, they had a community hospital, which had maybe 20 to 30 beds. And by halfway through, I think my second year as a fellow here, that hospital got shut down, which you guys maybe are familiar with, a lot of rural hospitals getting shut down. So you're talking about Camden, which even with the rural hospital, if you were going to have a premature baby, if you had hypertension during pregnancy, those kind of things, you still had to drive to Selma or to Montgomery to get your prenatal care because they didn't have capacity for you. To now you don't even have the ability to stop at your community hospital to get triaged, stabilized, and life-flighted to Selma or Montgomery. And so I say that to say that like I said, the Navajo Nation really shines a light on the disparities that we see throughout the country. It is by far the most shocking and the most appalling and the most devastating disparity as far as COVID-19 in general, but even things like diabetes, alcoholism, mental health. But for those of you that oftentimes don't relate to things that are not in your backyard, I challenge you to go to Camden, Alabama. I challenge you to be in Wilcox, Alabama. I challenge you to be on the border of Texas, the Texas-Mexico border. I've worked there before too. And there are American citizens that don't have running water that have to walk a mile to go get water from a well. So just thinking about those things.
Y'all made excellent points, more than I could have asked for, honestly, and I am truly impressed, and thank you again for coming. So let's move on to the next point. So the role of underlying conditions. So as we all know, there are some conditions that give you an increased risk for contracting COVID-19. And when we take a look at them, hypertension, diabetes, cerebral vascular disease, COPD, which is chronic obstructive pulmonary disease, and asthma. These are all things that you see increased incidence in Black and Brown communities. And like, we kind of rack our brains like, and I've heard students and attendings, unfortunately, really take things like this and conflate race and biology. So instead of them saying they have hypertension because they have experienced racial trauma throughout their entire lives, they say they have hypertension because they're Black, when there is really no connection between the two. So panelists, do you have anything to say about that?
I think I kind of mentioned it earlier, but just the focus on comorbidities is just always, I don't know, like, just makes me angry, like, especially in light of the last stats. Like, COVID is just showing like the seams, right? Like, these are things that have always been there, that COVID and just like everything is just like showing the rips in it. But for example, like regardless of hypertension, diabetes, like the morbidity of them in Black and Brown communities is just statistically significantly higher. Like, if it was like, you know, if it wasn't anything, like it should be the same, but it's not. And part of that is just the, like, where these communities are living, right? Like, they're like, I grew up in the south side of Houston. My family, like, are all essential workers right now. For the last 2 weeks, they've been quarantining because one of their coworkers tested positive for COVID, but they still had to go to work. Like, they were still going to work because they had to. They don't have paid time off. Like, they like make it work, but like, that's because they have to, right? Like, they have to like pay rent. They have to like do all these other things, and they have to live like on one side of the city and commute to the other side. And, you know, it's just, I don't know, like it's like a disconnect, right? If you never see those communities, if you're never there, like, of course you're going to say like, oh, like, they're Latino, of course they have diabetes. But if you're never there, if you don't go into the community, if you don't see, oh, it's a food desert. Why is it a food desert? Oh, there's a highway that literally crosses over it. Oh, like the bus route, like there's only 3 bus signs like in the area. The roads are all completely broken down. Like it's structural. It's not the people, it's structural. And if you were there, like, it's, you think of yourself as a flower, right? Like, if you put a flower and seeds and you plant them in like crummy ground, like, of course it's going to struggle. Of course it's barely going to function. So those are my thoughts here. Sorry, I was rambling.
The rose that grew from concrete is what I would encourage you to think about for people that aren't familiar with that. But I agree with you, Edgar. I think that's why it's so important to start to shift the conversation from race to racial to systemic racism, and how institutions are playing a role, because that's really the reason why we see what we see. It has nothing to do with whatever color of the skin that you have or what country you came from. In many instances, it has to do with when you get to this country. We know that even being one generation into this country, you start to see these disproportionate numbers if you're a person of color. And so it's really talking about systemic racism and institutionalized racism as opposed to someone's race. And the other danger of talking about race, specifically when I think about like the people that the MHRC serve, is that then you get people and they don't want to, when you say that, by the way, if you do happen to have these, regardless of your color, you might be someone that's more at risk for a more severe course with COVID-19. Nobody wants to claim that they have hypertension. No one wants to claim that they're obese. Nobody wants to claim those things because they always remember, well, Black people are obese and I don't think I'm obese and I'm tired of them referring to me as being obese. I'm tired of referring to Black people in general as being obese. So people start to distance themselves from their actual medical history, and it makes it our job as clinicians, as researchers, as advocates, as teachers, that much more difficult and challenging. And I can't blame them. If you're constantly being told that you're X, Y, and Z, you at some point distance yourself from that and choose your own narrative. And I'll speak as a person that went to an HBCU for medical school. Even in medical school, even though I'm being taught by maybe 50% of my teachers were African American as opposed to like 1% at a white institution. But even with 50% of my professors being African American, every lecture was African Americans are 10 times more likely than this, 2 times more likely than this, 3 times more likely than that. That gets old. And for those of you guys on the call that are people of color, I challenge you to think about how hearing your particular race, sex, gender, sexuality, how hearing what you're more likely to experience over and over and over in your training has done to your psyche.
I think what I wanted to say on that was that pretty much these are pervasive comorbidities that aren't just exclusive to one community. I think it more so has a factor to one, again, going back to the systemic racism part of it, if it's a systemic level problem, because considering that investment for major grocery stores, investment for all these different things doesn't happen in areas that are low SES to begin with. We're going back to the foundations here of redlining. We're going back to the foundations of years and years and years of history within the United States that has created these food deserts, that has created these financial deserts, that has created these lacks of opportunity basically for these individuals. Because for me to come in here and effectively be an immigrant, because I came to the US in 2005 from Bulgaria. My parents and I had $300 to our name. I lived in my grandparents' basement for like 5 years. But basically I was still able to climb out of that as a white woman, which again pains me to say that I have more of a voice as a foreign immigrant white woman than a Black woman who is a US citizen. And that was something that always struck me as really bizarre. And that is something that always struck me as horrifying, because I'm like, I am a foreign citizen and somehow I have more of a voice because of the color of my skin. And somehow I have better opportunity cost, to basically go and progress in my career than somebody who was born and had the same kind of financial situation as me within the US. So those were kind of huge factors for that. And then going back to the food desert part of this, really asthma is also an inner city problem. There's been thousands of studies within, inner cities where Black communities tend to be more prominent because of redlining, because those are industrial complexes where a lot of the industries will basically set up their plants because it's cheaper, right? So that's the thing, is that it is more of a financial investment thing. And at that point, these communities are now facing smog. These communities are now facing all of these other issues, which of course create a burden of disease like asthma. And unfortunately, because of the healthcare system being the way that it is, even with CHIP, these children can't get their asthma medications covered because they're so expensive. So these children are therefore unable to avoid these bronchodilators that are critical and life-saving. And then what happens is that we get this perpetual cycle of comorbidity of disease. And unfortunately, unless you find a way to break out of that and you shut down the self-fulfilling prophecy idea of it, that is where, a lot of people will have a challenge of breaking out of that, because it is demoralizing for someone to tell you the same thing over and over and over again. And eventually you kind of accept it, but you also don't want to, because it's like, why am I being defined by this idea of who I am just because of the way that I was born? It is a very demoralizing concept that you can try and distance yourself from, but it does get to you at the root of your psyche eventually. I have many friends who are basically just like, well, you know, I guess that I'm an idiot because of this and this. So it's horrifying to think, but it is a large factor for why we still have to continuously combat and advocate for these patients. And it's really important that we as future physicians have a good idea of that.
So actually, I want to bring up a really good point that I just got in the chat. And this is from Sujin. She's my classmate, MS4. She was talking about coming to medical school and taking exams. I'd be missing questions because I was not getting the cues in the question stems. Patients being described as African-American immigrant from East Asia, ACC, were supposed to be the cues, but we were in a way taught to be discriminating and judging patients based on their background for their healthcare. So this is actually really big because I have had notoriously bad standardized scores because I do not understand what the question is asking me because I'm not able to look into the lens that they're trying to get me to look into. And I've noticed that that is why I'm missing all these questions, and I can't do anything about it because I'm not unlearning that. So that is a big thing. If you want people to be coming here to be excellent doctors, but you're not, you know, being culturally human, what am I trying to say? Culturally sound in your questions, then you're just teaching us to be discriminatory. And that's one of the biggest reasons that we have such giant health disparities, because we have been training doctors to be racist. And I've actually seen multiple questions that we're still like in UWorld right now, in multiple USMLE forums that are surrounding ethics issues that are so out of touch from actual reality. I remember one, it was about a woman who was wearing a hijab, and she needed some life-saving procedure done in the presence of a male doctor, and the patient was like, you know, I can't do this without my husband here. So, and then the question kind of asks you, what do you do in this situation? And some of the choices were you do it anyway because her husband is there and she needs the procedure, or you try and get a female nurse in the room so she feels more comfortable. So, you know, me, I'm thinking, all right, let's get the female nurse in so she's more comfortable. That was not the right answer.
That was wrong too. I remember this.
I was like, that was not the right answer. And like, people are missing stuff, and that is not what we were supposed to be. Like, you're missing the whole point in such a critical point in medical education. So I really think if we're gonna be addressing these health disparities, what we have to do is really address race-based medicine and all of these like BS kind of theories that exist. And I wanted to talk a little bit more about the hypertension in Black people that I brought up earlier. Dr. Nadine Burke-Harris, she has a really good TED Talk on childhood trauma and how repeated activation of the fight or flight response in your RAS system can lead you to develop these underlying conditions in the future. And that's why we see such high, I just wanted to explain that because I just kind of said it and left. But so this is one of the reasons why we see these increased incidents of hypertension, diabetes in Black and Brown communities. And childhood trauma is one part of it, but I think, you know, Black and Brown children are acutely aware of racism in the United States. We're exposed to it on a daily basis. We have our parents there to sit us down, give us these extra talks on how to keep ourselves safe in a community like this. But at the same, they don't tell you how to handle it when someone calls you the N-word when you're trying to do something, or you're just minding your business, living your life. Like, so there's just this huge disconnect as far as like the trauma we experience, how that trauma compounds itself, and we see a physiological response that nobody's addressing. And we're kind of being blamed for things that were external. So with that being said, let's move on to the next. Oh, Dr. Hill, did you want to say something?
Again, trauma-informed care is super important. Myself and a couple people in my division specifically work with residents, and then whatever students come through on recognizing that it's this idea of, instead of like when the angry parent, the angry kid, whatever comes in front of you, and you're looking at them like, why are you acting like that? Instead of having that response, it's the response of like, okay, what could possibly have happened recently or not so recently that I'm seeing play out, and realizing your own emotions in response to what you're seeing, and pausing, and then resetting yourself to actually focus on the patient as opposed to your physical reactions, and getting the patient trauma-informed care. I was also going to say, Farrah, I can definitely send you slides on on ACEs, and how there's actually a correlation between however many ACEs you have and those cardiovascular conditions on the last slide. It also correlates with STIs and HIV. I mean, it correlates with a lot of things.
I just realized I mute myself, but thank you, Dr. Hill. So if we go on to the next slide, so we're kind of like, what's the deal with all of these underlying conditions and all these disparities that we're seeing with COVID? So I listed a few that I found in articles, and I really want to expand on these because it's not a comprehensive list, right? But we have proposed delayed healthcare seeking behavior because of the inferior care that Black people are notoriously given. So people are not going to go to the hospital if they have multiple stories of medical mistreatment. I have medical mistreatment stories. I still go because I need the help, but like it's a travesty. I honestly, you can ask any Black person, they have a story of medical mistreatment, and it is a shame. It is an absolute shame, and it contributes absolutely to why people are not seeking treatment for COVID. Also, educational and linguistic obstacles. So people, you might say, hey, I have this pamphlet on COVID-19, here, read it, you'll be safe and you'll be good. But hey, what if I can't read, or I don't speak English? So, and this is only in English, you didn't give me a Spanish version. So these are all things that we have to keep in mind. And I did talk about the difficulty in trusting authorities, especially with immigration, talking about that as well, because healthcare and immigration are not, they should be intertwined, but they're not. And then financial, we talked a little bit about this, and I do want Edgar to talk a little bit more about the essential worker workforce. Sorry, y'all, my computer just randomly does this now. I do not want y'all reading my emails, good gosh. How do I close this out? Okay, thanks. All right, so Edgar, can you talk a little bit about the essential worker workforce a little bit? Thanks.
Yeah, so nationally, the essential workers are typically considered service, production, or like custodial staff. And I was only able to find service or production worker stats, but about 45% of the workforce that is service or production, so think factory workers, think restaurant workers, are Black and Latino, compared to about 1 in 4 white workers holding these jobs. These jobs tend to not, I mean, I don't know, they're essential right now, but they are not traditionally the jobs that make the money, right? Like they are quote unquote unskilled labor. They are farm workers like out there harvesting our food right now. They are the people making the vaccines, to be honest. And it is one, not the most highest paid position, usually not unionized. And so if they don't have a union, they have no one kind of advocating for them and kind of instituting paid sick leave, for example, paid maternal leave. And I think just that stat alone to me is a huge correlation in just the exposure, right? Like if you're out working because you have to, you will be exposed. If you're out working in a factory, if you've ever been to a factory, if you've even seen Charlie in the chocolate factory, you've seen how tiny these things are, right? Like you are literally right next to the other person. And it's like throwing people to the wolves, essentially, right? It's like, not to get a little socialist here, but like it's literally like saying to people, this is your worth, and with these risks, right? Like right, they're at even more risk right now. Like they've always been at a risk, but they're at an even more risk right now. And there has been no like unionized effort apart from a couple corporations after like some you know, like Amazon, right? Like Amazon has been launching, if you watch Hulu, like they have these huge campaigns about like their essential warehouse workers, but they haven't actually been paying their warehouse workers more. And there's been all these stories coming out about how hard it is to actually just take a break and like, I don't know, like relax, right? And so I touched it earlier, but you touch on that idea of like these people, 45% of these people are essential, and they usually live in the most underserved communities, and they're commuting from place to place, usually, not to bring this up, like usually, so nationally, the percentage of Black and Latino folks who own their own homes is only 40%. So they are probably living in apartment complexes. They're probably living close by. So it's just like one thing stacked on top of the other, stacked on top of the other, stacked on top of the other. That's just making these communities more exposed. And it's not, it's back to that comorbidities thing, right? It's not the fact that they might have a higher incidence of diabetes or heart disease. It's they're out there on the front lines, and they don't know how to advocate. Like they don't know how to advocate for themselves. One, because they don't have, in my opinion, right? They don't have the brain space to sit down and think through this, because it's the Maslow's hierarchy of needs, right? Like they're worried about getting food to their table. They're worried about providing for their families. They're worried about making the next paycheck. And you take that thought of the essential workers and you take the idea of the racial wealth gap, and it's like F, right? Like, so I'm gonna read these stats that I have pulled up from Brookings Institution and Urban Institute about the racial wealth gap, just to understand why there are so many essential workers that are Black and Hispanic, and Latino. So the racial wealth gap isn't necessarily how much you're earning, it's literally how much, like what capital you have saved up. And so there was a study that examined 1999 to 2007 and examined the net worth of Black families, white families, and Latino families. The median net worth of Black families was about 18,000. So that's considering like the debt they owe on their houses and any investments they have, and whatever property or real, like any investments they have. Hispanic families did a little better, 33,000. But white families have a median net worth of 122,000, right? So that's, I mean, like, that's just, like, it's almost 10 times what Black families have. And so you tell someone they're essential workers, they're out working, and they're exposed, right? They're not thinking like, oh, I have money to fall back on. Like, right, they're probably at a deficit. There's no cushion there. So when we blame them, like that's not their fault. It's more like, why didn't we understand that? Like, why aren't we as future healthcare workers, current healthcare workers, like acknowledging like this huge, like it's part of that healthcare disparity. It's not only in COVID, but just everything, right? Like there is no brain space to think, and there is no brain space to modify your lifestyle, right? There is no brain space for even if you wanted to go to the doctor, think, okay, so yeah, exactly that. Like, if you wanted to go to the doctor and you're an essential worker and you have no sick time or like limited sick time or paid time off, like when are doctor's offices open? They're open during the day, during like 8 to 5. That's when they're working. Or they're working night shifts and they're sleeping during the day. And our urgent, like right now, most of our urgent care centers are closed because of COVID. So where are they going? Like, yeah, that's, sorry, I ranted, but it just.
Edgar, you're on point. I mean, for your last point, the urgent care, we actually got 2 new patients in the clinic. They walked into our clinic because these were 2 teenage young men And their mom brought them, she had brought them to the urgent care, and she saw the line wrapped around the building. And she had just enough brain space to be like, yeah, I already took this time off to bring them to the urgent care for something in their ear. One of them couldn't hear well. I'm not going to stand in this line and possibly get COVID waiting for hours to be seen for an ear, and walked into our clinic to get services. But it's exactly what you're saying. And as medical students, I can tell you guys, you have to retrain yourself, if you don't already think about this, to find solutions that meet your patient's need and not what the book has told you. I've had patients walk in, and there's actually a Latino family I remember very distinctly. It was the mom and the daughter that walked in, and the daughter was showing symptoms that could be COVID-19. And so we were testing, and the mom said, well, we don't leave the house. And I said, well, who else is in the house? Dad is in the house. And I said, okay, well, what does dad do? Dad works at a restaurant. And not only does he work at a restaurant, but he comes home for lunch to eat. And, you know, in the end of the day, dad is very cognizant. He takes off his work clothes before he does anything with the family. But during his lunch hour, you know, that's not a full break, because he's got to travel to get there. He eats and he goes back, and he's not as cognizant of, let me change clothes and then go eat and then change back into work clothes and go to work, because that's just not feasible. That's just asking a lot. And so simple things like that, if you're not able to ask the questions to get at her risk for COVID-19, is really just because her dad is still trying to make ends meet and happens to be able to come home and enjoy a nice lunch and save money by eating with his family. You know what I'm saying? But yet he's possibly exposing them to COVID in between because he doesn't have enough time to change clothes. Then you're doing your patient a disservice, because you're really not dealing with the exposure, which is a unique exposure for that family.
And I actually do want to hear more of these stories. So if the audience has like any stories about medical mistreatment or noticing any disparities based on socioeconomic status, race, or anything, feel free to share, because y'all a little quiet. If not, I can go to the next slide, but I'm waiting in the chat. So we're wrapping up. So this is why I want y'all to speak up. COVID-19, it's basically putting the U.S. healthcare system to the test, right? And honestly, we're failing. And we spend a lot of this time talking about the disparities, what we're seeing, some of the reasons behind that. So does anyone have any, wrapping up thoughts, closing thoughts to take us home today?
It's going to take a while to basically go through this. There is a lot of factors that we really have to address, and I'm like thinking of a really good way to really start pushing on that, but there was a really good systematic review of what basically are current factors in structural racism and health inequities in the US. This was a 2017 paper, which was actually part of a series called America, Equity and Equality in Health. This was published in The Lancet in 2017. It's by Bailey et al. But basically, they have kind of a multifactorial approach to this and have gone through and identified how really structural racism is a great foundation for healthcare inequity and disparities. And they do identify certain points for how we can improve that. I do recommend giving that article a read if you do have time. It is easier to understand than most scientific literature. It's not as dense. So I will say that it is okay for people who are interested in just learning more about that. It is pretty great. And in summary, I think that from my perspective, there's a lot that we really need to start working on, but really education for our physicians and I don't know how to describe this. Sorry, I'm having an English as a third language problem here. I think culturally competent and also socially conscious education for our patients would be where I'm going with that, is that we need to basically start thinking at the level of somebody. And I think part of that is really compassion and part of that is empathy, having the competency and the ability to put yourself in that patient's shoes, to imagine their circumstances, to really take the time to get to know them as an individual and find out their individual challenges before you actually start addressing their healthcare issues. to find out what their reservations are, to probe and ask those questions before you start really digging into the meat of what their healthcare problem is. And unfortunately, that barrels down to time, because the average time for a physician seeing a patient within the United States is 7 minutes. The problem is that we just don't have the sufficient resources to really care for our patients, and that is in and of itself a giant burden for current healthcare system providers, because as a whole, we need to spend more time in order to do that. But right now, health insurance and even directors of medical hospitals and even just regular urgent care outpatient centers really do treat most practitioners as an assembly line of workers. And healthcare is less so about patient individual care and more so about getting numbers for the insurance companies, which is where it really is a huge detriment to our patients, that we cannot spend as much time as is necessary with them to really help to address these issues. So that is another consideration that I think nobody's brought up so far, but it is a big thing that has been on my mind for a while. One of my personal private care physicians, my endocrinologist, actually quit her clinic and started her own because of that exact reason. She was just like, I am fed up of not having, being told I have this much time to spend with that patient, and if I don't see X amount of patients within this day, then basically I'm not meeting my quota for this clinic. And that is pretty much, I think, where we can start to change or shift that. But that would also require more communication with our healthcare insurance companies and our hospital directors as well.
I think Allah wanted to speak.
Yes, hi. So first, thank you all for your perspectives and your stories. This is definitely an important conversation. And Farrah-Amoy, thank you so much for all of these sessions that you've been having, because I think this is a conversation that should have happened a long time ago. But I kind of wanted to just take some time to answer the question in your conclusion slide. So in terms of how the US is doing with its response to COVID-19 and whether it's inadequate or intentional abandonment. So from my perspective, and I generally have a more negative perspective on these things, but I think that I think a lot of people would agree that the response is not super great. And it's lacking in a lot of different ways, but I do think that one big way is this whole conversation has been talking about how COVID-19 is affecting Black and Brown communities in a completely different way than in other communities. And I think in the beginning of the pandemic, we were all thinking that this was like the great equalizer, like everybody was being affected by this disease and everybody like was going to come together and all this stuff. And then we realized the disparities are being illuminated. I think 2020 in general is just showing a lot of cracks in, I don't want to say like, I guess in the system and in our world, how a lot of things are like becoming more obvious. I think a lot of people could hide behind it before, but in particular for health disparities, it's definitely showing those cracks. And I think that the reason that the response is so poor is the constant denial of how this impacts different communities, particularly communities of color. And in that way, it's inadequate because they're not responding to those needs of those communities, but it's also intentional because I think it's willful ignorance rather than just not knowing, because there's just too much evidence and there's too much research that's been surrounding health disparities in general that it's kind of ridiculous to assume that they just don't know how these are impacting different communities. And the way that the president has responded, especially like responding to WHO and CDC and Dr. Fauci and all these different people or groups that have the knowledge to make statements about this and like kind of completely disregarding it, kind of shows how intentional it is. And the detriment is not really going to be on white communities, it's going to be on communities of color. So that's just negligence in my opinion.
Yeah. I thank you a lot for those comments. That was right on point. I wanted to share my, I guess, hopefully concluding word. I'm like Edgar, I can also rant as well. But I want to share a story, and I share this because maybe not for you all, but for many people I work with, this is common knowledge that I suffer from fibroids. And I want you to put yourself in the perspective of me as a third-year resident, going to have plans already matched into a fellowship program. And one day you have probably like the worst period you've ever experienced, where actually a large amount of tissue has come out. And it just happened once, that's it. But you know something's wrong. You go to your doctor who you have an established care with. So if you don't have a doctor in med school, get one. But you go to the doctor who knows you. And this particular doctor was a gynecologist, white female, no issues. And you tell her your experience and that you need to get, your hemoglobin checked and your crit checked, because you're pretty sure by now it's probably dropped by the time you're able to get in to see her. And no, in any kind of language you can think of is what she's saying. She's like, you're fine, you probably are distressed, you're a resident, right? And then the question that goes through your mind is, if I was a different color, what would your answer be? But you don't say that. Instead, what I say is, I'm very positive that this is different. I work out 7 days a week. I do 2 a day at that point. I do 2 a day some days, even as a resident. After a 30-hour shift, I go work out. I'm in good shape, still overweight at that point, but I know my risk when like something is wrong. And here's what the physician says to you. Okay, I'll oblige your request because you're a physician. That's what she said to me. Now, if I had turned out to be healthy, this wouldn't be a story, right? But the reality is, she calls me on a Saturday morning at my 8 a.m. workout class where I'm lifting weights at the gym. And I pick up the phone because I recognize her number, and she's panicked. And my hemoglobin is 5 to 6. Mind you, I've still been working as a resident, which is an 80-hour work week. I've still been doing my 7 days a week with 2 a days, many days workout. I'm definitely tired and fatigued, but honestly, life as a resident, sometimes you might not notice the difference in fatigue. But 5 to 6 is what my hemoglobin is. And she's like, are you okay? What are you doing? I was like, yeah, I'm fine. And when she told me that, it wasn't even a freak out of like my hemoglobin was so low. It was more of like, yeah, not surprised. Not at all surprised. And so she gets me in to do an ultrasound to see why it's so low, because all of a sudden she's all worried now, right? Even though I was worried when I initially went to her. And the ultrasound tech, the only thing that she can comment, and this is she just happens to be another white lady, not relevant, but the only thing that she can comment is like, oh my God, did you know your uterus looks like this? That's the only thing she can comment. And then her next comment is, well, you guys usually have to have your uterus taken out anyway. You guys being Black women, by the way. That's the ultrasound tech. She did not violate her job, meaning she did not tell me my diagnosis, right? Because that's not her job description. But that's the conversation that we have. And mind you, again, guys, you may not be able to relate, but you're lying on a table. Someone is in your vaginal area with an ultrasound probe. And the comment that she has is like, you guys usually have to get your uterus out anyway, right? So again, she doesn't know I'm a physician. She doesn't know any of that. She just, I'm just Joe Schmo, which is fine. So then I go back to my OB, and my OB says what I know she's going to say because I know what color I am. And she says, okay, well, let's schedule you for a hysterectomy. And because I am me, Samantha, and I refuse to take my uterus out before I have children, that's my own personal preference, please don't be me. I said, nope, no, thank you. And I moved on and found another doctor who also said the same thing. I said, no, thank you. Long story short, I finally found a doctor when I moved here to Birmingham after almost passing out in clinic several times, because as a fellow, I didn't feel like I had the power to say, I'm not feeling well, I need to go home. Meaning I would arrive to clinic, I would arrive to the hospital park at 6:45 a.m. and my clothes would already be soiled from going over speed bumps and things like that, and I'd have to change. I finally found a surgeon who was willing to operate and not take my uterus out. But I say that to say, imagine right now in COVID-19, the same thing is happening. You have people coming into the clinic and they say, I don't feel well, I have a fever, and they're being told, oh, it's probably nothing, go home, you don't meet criteria, so on and so forth. And then within the week, they are not only diagnosed with COVID-19, but they're in the hospital because they have COVID-19. And so I say that, one, because I need you guys to understand that just because you are physicians, or if you happen to be a physician of color, a physician that's from a different ethnic, racial, religious, sexuality, background, whatever, you are not immune from the mistreatment that has been happening in this country for decades. But I also say that because it is our job as physicians, future physicians, to make sure that we are not doing what happened to me, what happens to other people, to our patients. We have to be advocates for our patients. We have to listen. We have to take a step and be like, wait, is that my bias coming through? So that's really why I wanted to share that story.
I will just add, because I just thought it was hilarious that my father said this to me. My father is a very typical Mexican, like very stern man. Just on that, like, he was like, I don't have time to think about this, but like, you will, like, right? Like, we have the privilege, and regardless of, like, I'm saying this knowing the minority tax is a thing, right? Like, we have the privilege to, like, be getting paid, like, we're gonna get paid to think about health, like, right? And there are many problems with it, and like, if we don't talk about it or explore it like we're doing here, like, it'll stay the same.
So, Dr. Hill, thank you so much for sharing that story. It actually reminded me of a similar, well, it's not similar at all, but it's around COVID-19, and there was a male paraplegic patient who had COVID-19. He was in the ICU. All in all, his outcomes were not that good, and the doctors were wanting to basically pull the plug on him. And the mother who was in there, she kind of turned her phone on to record because she really couldn't believe her ears that the doctor was talking like this. And he talked about how the patient didn't have, good quality of life. So there's really no reason to, try and uptake his care. So that's another thing, like, we as physicians, we have an idea of what quality of care is or quality of life is, but that may not be the same for somebody else. So for us to even like say or think or impose our idea of that on someone else is extremely rude. And I think it tied really well into medical mistreatment, especially on the basis of implicit bias. So I think those are my last words, y'all. Does anyone else have any closing comments?
I think Allie wanted to say something.
Hi, I'm Allie. I'm an MS3 and we just started clinicals. And I just wanted to add that as medical students, it's very important that we're very intentional with our word choices because other people are listening, other people being the nurses, the tags, PAs, PTs, because I've heard women be described in terminologies that you would never and never should talk about a woman in such a way. And especially, for example, we deal with a lot of underserved people at the hospital. So just naturally at an academic institution, you're working with minorities predominantly and those who are uninsured. And comments are made such as like a physician would come and one physician was talking about a Black woman and said, "What a fat F." And that was appalling. One, from it becoming a physician, from a physician, two, it was a male Black physician. And I don't know if the nurses thought that it was okay to articulate that because it was coming from a physician of color. But then I started hearing it being repeated over and over again by residents, by faculty members, by nurses, by staff. And it's difficult when you're in a position and your higher uppers are telling you that, and you're the one who's trying to educate them on, well, let's talk about like why that is. Why are we seeing more obese women of color? The social determinants, no one seems to want to talk about it. And especially like after pregnancy, it's important to get them up and start moving. So when they have these biases, like they're such a big person, I'm not going to want to work and make that extra effort to help them get out of bed. You're putting them at so much more risk than they need to be. So just something to think about, that when we say things and the words that we choose, we need to be very intentional with them because we are in a position of power that people do look at. And I think that's important because that's just one of many examples that I could share from the past 2 weeks that I've been in clinicals. And I've heard a lot of stories about it, but this is something that now I'm experiencing. And I feel like I need to say something and to have these conversations with my peers about. And thank you so much for putting this on. This has given me so much insight and perspective, and hopefully we can get more people in the conversation with us next time.
Thank you guys so much for coming out to the first public session of Laid Black. Signing out until next Saturday. Y'all know where to reach me. And yeah, goodbye, everyone.